Good morning, everyone. Lovely to be with you on stage, Sachin.
Great to be with you.
I want to thank the organizers. This is my first time at this conference, and I have learned so many acronyms over the last 24 hours.
Which one is your favorite one?
ESI, and you didn't know what it was.
ESI is Express Scripts.
It's employer-sponsored insurance.
Okay, fine.
Anyway, moving on. So, state of Medicare. How do we do this without getting super political? I'm going to try.
I mean, Medicare is a very boring industry where there's absolutely no change.
No change.
No change.
All right, let's talk. So combined spending on Medicare Parts A, B, and D rose from $583 billion in 2013 to $1 trillion in 2023, and is expected to double to US $2.1 trillion by 2033. We are in expense-cutting mode. How do you rein in spending, especially given the major demographic shifts we're seeing?
Look, I think one of the biggest challenges that we have in healthcare is we talk about total costs, and we don't actually talk about the breakdown of those costs. And the truth is that there's a price issue in healthcare, and people have said a lot about price, but there's also a quantity issue in healthcare. And I don't think we talk enough about the quantity of services, the quantity of unnecessary services that are consumed. And when I say unnecessary, I mean services that are delivered because people have preventable progression of chronic disease. And I think the Make America Healthy Again movement has a lot of components to it. But I think whether you're a Democrat or a Republican, I think you can agree on the fact that this country has been focused excessively on service delivery as opposed to actually producing health. And it all goes back to how we pay for care. And the truth is that we don't actually pay for health, we pay for services delivered. And so we get the system that we actually have, which is one that continues to feed itself by creating more services that people can consume. My father was actually somebody who was diagnosed with diabetes at about the same age that I am. I'm 44 years old. What ended up happening over the next 30 years is he developed complication after complication of diabetes. He had cardiovascular complications. He ended up on dialysis. He ended up having neuropathy. And then I was in medical school as a 22-year-old student, and I was reading the Diabetes Prevention Program study, and I was thinking about the fact that diabetes is actually a preventable disease, but we never actually see it that way. We see it as an inevitable outcome of having bad genes if you're a brown person in this country, which I am. The truth is it's actually a preventable disease. It actually can be managed, and we've never really treated it that way. And actually, as a medical student at Harvard, we were never actually taught to see it that way, except for maybe this one class where we reviewed the Diabetes Prevention Program study that was published in 2003. So all I'm saying is that our focus has just been really misplaced. And I think that's why Medicare Advantage is actually one of the real missed opportunities, candidly, because I think Medicare Advantage in pockets has been really focused on prevention, but writ large, it's really just taken this fee-for-service system and then kind of applied it to a private insurance model. The next 10, 15, 20 years, if we're really thinking about making America healthy again, we're gonna focus much more on upstream prevention, managing complications. We're gonna focus on actually getting to people before they hit 65. We're gonna focus on products that actually have people in them for more than a year, because you can't do value-based healthcare in one-year increments. And so again, I think that there's an opportunity to revolutionize how we think about the problem of serving older adults. And the truth is that this is an outgrowth of history. Medicare was created as a hospital program in the 60s to insure against unexpected hospital costs when the life expectancy of Americans was in their 50s and 60s. We have a very different country today, and so we have to build a different kind of Medicare program, and there hasn't been the kind of fundamental look at the chassis. Instead, we've added Part A, Part B, Part C, Part D, and the truth is that if you were really thinking about government efficiency, you'd be like, all right, let's actually think about what we really need to serve the people that we need to serve today.
So I'm going to push back.
I'm surprised. I've never known you to push back, Arundhati. We've known each other for a long time.
So you're trained to be an optimist. Journalists are trained to be cynics. what you said about Make America Healthy Again is actually very, very apt in this environment that we are in. But when we go further and further upstream, as you want Mr. Kennedy and team to go, you run into the food industry. And the food industry is not going to give up that easily, right? We can disagree with Mr. Kennedy on vaccines. Most rational people will do that. However, I think most people do agree that our food industry is really feeding us a lot of bad stuff. I mean, I don't know if you know, but in Europe, the Doritos that get sold don't have that orange coloring in it because they think that's really bad.
Coloring.
I know you love that orange.
Sorry.
Well, I think we all love orange as a nation, right? Given our president.
Well, let me say the following about this, because I think it's an important topic. You know, these are very high pressure times in this country, and there's a feeling like we're in the heat of the moment right now. And certainly this is a very hot moment for all kinds of reasons that I think we all know and acknowledge. The truth is that we're in the first inning right now of a rethink of American healthcare. This is not the second inning, the third inning, the fourth inning, the fifth inning, or the eighth inning. This is the first inning. The kinds of conversations we're starting to have today or in the last 5 years, really, and it's not really just about this administration. There's the longevity movement. There's a new science of aging that I think people are really talking about. There's a different perspective on what primary care should look like. There's even an evolving perspective that we should start thinking about health in more than 1 year cycles, right? And the truth is that this broader rethink of American healthcare starts with really thinking about how people live and how people age. And it's not linearly, right? And I think, unfortunately, just because of the way we insure this population, we think about Medicare as the 65 plus program. And I think if you really wanted to think about a new Medicare program, you would think about one that maybe starts enrolling people a bit earlier or gave people the option to enroll in it a little bit earlier if for whatever reason they don't have access to employer-sponsored coverage. So expand the market for Medicare beneficiaries, and then start really thinking about what is it that you do in people's 50s that lowers their healthcare costs in their 60s, 70s, 80s, and 90s. There are a number of organizations. I used to be part of CareMore Health. Kaiser Permanente does this. When you own somebody over the life cycle of their care, you ultimately can do things when they're 50 that influence their health when they're 70. But the truth is unfortunately, our industry thinks about people in 1 year increments. And I don't know about you, but every year as I get older, it goes by a lot faster, and there's much less to actually do in the course of a year. And so the question just becomes, how do we think about this as a long-term investment? And unfortunately, we're like thinking about this as 1 year shorts. It's not the way to do healthcare.
Okay, so you talked about Medicare Advantage, so let's look into some of the numbers. MA is super popular. 2024, 32.8 million people were enrolled in a MA plan, accounting for more than half or 54% of the eligible population. What's the reason behind the popularity?
Oh my God. It's really simple. Traditional Medicare is a broken program.
Okay.
And there's a lot of people who take aim at Medicare Advantage because it's popular and because it's expensive. And I think there's a lot of work to do to fix the Medicare Advantage program to make it a better program. But we don't talk enough about how broken traditional Medicare is. And all you need to do is talk to somebody who's like an average older adult. And I think everybody in this room knows these folks. Married couple, aging into Medicare, their average income is about $54,000. Let's assume we want to put them in the traditional Medicare program. Their Part B premium is $184. Then you put them on the hook for a Part D premium, and then you give them a Medicare supplemental policy. So they've spent their entire life paying Medicare taxes. It's almost April 15th. People are looking at this big number that they paid into Medicare. So they paid it their entire life. And at the very end of their life, they have the privilege of paying $12,000 of their $54,000 income to pay for their health expenses. So it's a fundamentally broken system that does not look anything like what Harry Truman originally imagined when he kind of imagined the Medicare program and when Lyndon Johnson signed it into law. This was supposed to be an income protection, a security-oriented program. Now compare it to Medicare Advantage, where you still have to pay a Part B premium, but your Part D might be covered. You may have a small premium or zero premium for the plan, and you have a predictable set of expenses. When you're on a limited income, this program just makes a lot more sense. And all of the critics of Medicare Advantage have, I think, reasonable gripes, but they fail to realize that traditional Medicare is basically a bourgeois-oriented program at this point. And again, if you can afford it, it's great. But look at the real state of most people aging into Medicare today, and they simply can't imagine spending $12,000 of their Social Security income on additional healthcare expenses.
So your eyes just lit up when you talked about the advantages of Medicare Advantage. But let me tell you a couple of stories that we've written. So MedCity News is a healthcare publication. We're a B2B publication, online, free.
I want to compliment Arundhati. It's a great publication, even though it has a terrible name. One day, somebody will explain to me what MedCity is, but that's a different question. So.
No one cares about the history of MedCity, so we'll skip that part. So MedCity News has written stories about how hospitals and health systems are actually cutting back on their MA contracts because they feel that plans are not paying them well. They feel taken advantage of, no pun intended. But how does, first of all, is this criticism legit? And B, I'm guessing your health systems love you. How are you maintaining that relationship?
So I think it can be legit, and I think that there are some nefarious practices in the Medicare Advantage industry that need to be acknowledged. I think there's overutilization of utilization management. I think that there's oftentimes, health systems engage in get sold bad contracts and then realize it after the fact because they have so many contracts and don't really know what they're signing up front. But what I would say is the following. There's a lot of instances where I think what they're actually saying is they want to walk away from low-income people. I mean, there's sort of an understated message or an unstated message.
You mean health systems are walking away?
Health systems, absolutely.
Oh, that's a big charge.
It is a reasonable charge, and I would be happy to defend it. The other thing I'll just tell you is that this is a completely different business. And I think you have to change your processes to actually perform in Medicare Advantage. You have to code appropriately, you have to focus on stars. And the business, when you're actually in Medicare Advantage, the business in Medicare Advantage is actually keeping people healthy. To succeed in Medicare Advantage, if you're in a full risk-based contract, which is what you should be if you're in a health system, is actually to keep people out of your hospital, not get them into your hospital. So you actually literally have to change the hearts and minds. You have to stop feeding yourself through the delivery of services, many of which could be more cheaply delivered in lower cost settings. So you actually have to change. And the major affliction of American healthcare, to take it up to a higher level, is that everyone wants change without actually changing anything. Mm-hmm. Everyone wants to get paid more without doing an extra damn thing. And that's the major problem that we have in this industry. And so when these health systems are saying, oh my God, I don't wanna, I'm not getting paid enough, it could be the case, that could be true. But what could also be true is that they're not engaging in the more fundamental change that's required to actually perform and succeed in Medicare Advantage. You were complimentary about SCAN's relationships with our provider partners. We actually had one of the most significant terminations in the industry when Scripps actually terminated us and left lots of people without an HMO option in the San Diego market. And candidly, we were paying them a top of market cap rate. We were trying to work with them on kind of processes to actually perform better in Medicare Advantage, coding appropriately, focusing on your admits per thousand, and you want to actually lower your admits per thousand. But that goes against a traditional fee-for-service hospital system or health system model of actual financial performance. And again, when you have this business inside of a business, oftentimes you're not willing to make the changes to your chassis to actually do the things that you need to do to perform well in Medicare Advantage, which is a very different business model than most health systems actually engage in. Health systems are like almost every other business. The more you do, the more you get paid. Mm-hmm. In Medicare Advantage, it's really about making sure people are healthy, and that often means trying to reduce the number of admissions that you have to the hospital. And sometimes that can feel abrasive and that can feel like it's against your mission. But the truth is that there's a lot of older adults who are much better treated in outpatient settings than they are inside of hospitals. And again, you have to start thinking differently about healthcare if you want to succeed in Medicare Advantage. And again, we have a lot of dinosaurs in this industry in charge of big systems who don't want to change, but they want everything to change, and they want to get paid more to do it. And so, it's not news to hear that a health system wants to get paid more and more and more and more to do things. That's a new story. I've never heard that before. And to be fair to those health systems, they do the real work. I just want to acknowledge that. As a physician, they're doing the work of taking care of the patients. They see the patients, they admit the patients, they care for the patients, they discharge the patients, they follow up with the patients. So they are doing the real valuable work in our industry, but they also have to simultaneously turn a knob to a different way of thinking about patient care. And way too many systems want to kind of stay the same and just get paid more for doing the same stuff.
So, I've been in the industry as a journalist enough to know that no one's hands are clean when it comes to driving up healthcare costs. And
including journalists who throw big events. Anyways, I'm just kidding. So,
come on, man.
Those sponsorship dollars, those ads on MedCity News.
Just to be clear, no one's paying me to be here, okay? Okay?
That's true. I can attest to that. She's a volunteer here today.
So I include health systems in the mix of driving up healthcare costs, but I want to double down on this prior authorization. And there's some real animosity.
Nefarious practices, 100%.
And how do you contend with that? We constantly hear from the AMA and other people that prior authorization is now the biggest problem. EHRs used to be, now everyone sort of stomached EHRs, but prior auth is like killing them.
I agree. I'm not going to stand and say that I think prior auth is kind of been done effectively. A lot of what's happened in our industry, though, and I think people don't really fully understand the extent to which healthcare is still operating with 1992 technology, and what I'm talking about is faxes.
Right.
And so a lot of authorizations are kind of rejected just on kind of documentation grounds, and we're really kind of circling. When you look at the rates of initial rejection versus eventual rejection, there's just so much unnecessary friction. And I think industry-wide, we have to take a hard look at ourselves and say, why are we not kind of migrating more towards technologies that will enable real-time adjudication of claims? And I think that's where we're going. And I don't want to speak on behalf of the industry, but what I will tell you is all of my colleagues across the health insurance industry, following the murder of Brian Thompson, seeing all the negative reaction, are kind of waking up to the fact that we normalize some very abnormal practices in this industry. And the truth is that, sending people denials, sending people documents that they don't really understand, bring them to hospital systems where they don't actually even know whether their bill is going to be paid or not. This is lunacy, and we've created something that we can't be proud of. The truth is that we have to think. We are so committed to toxic positivity in healthcare. I was with a health system leader a couple of days ago, and we were talking about how, what needs to change in healthcare, and there was like repeating all the industry talking points, like access, quality, transparency, blah, 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 blah. And I'm like, no, let's just talk about how everything sucks for everybody. Because the truth is it does. And many of us, I started down this journey of trying to make healthcare better as an undergraduate student in 2001. That was the first glimmer of hope that I had that I could try to make healthcare better. 24 years into this journey. And what I can tell you is everything's gotten worse for everybody. But somehow we really don't say that out loud when we come to conferences like this.
Yes.
We drink the beer, we wear the sweatshirts, we normalize really like very abnormal things. And then and we're all doing well. We're all doing well. We're all making money off of it. We're all succeeding more. But the truth is that when we become patients, or when our loved ones become patients, we are just slapped in the face with how dysfunctional it is.
Sorry to interrupt.
Yeah,
Can I give an example of that?
Yeah, sure.
So I had an older brother, dear older brother, and we were just two. So he had cancer, and he died of cancer in 2017, stage 4 kidney cancer. Pretty awful. My parents are still alive, so you can imagine that situation. In the last 6 months, there were many trips that we had to take to the ER. He would suddenly get strange fevers, bad situations. After he passed away, I got a call from the ambulance company who called me and said, we're not getting paid by the insurance company. Like, are you kidding me? Why? And they said, well, we're not in their network. So imagine, if you're dialing 911, which I did a few times, how in the world are you going to ensure that they're going to send an ambulance company that is in network of your insurer?
And I don't know who your insurer was, but
Cigna.
But I'm going to say this. But with all due respect, what I'm going to say is the following. It almost doesn't matter, because if you were going to go to the webpage of Cigna or any of the other companies it could have been, you would read some BS about how they care about the whole person and the patient and the whole person centered gobbledygook, okay? Right? And their CEO would come sit on the stage and tell you that their company is amazing and fly here in their private jet and tell you how wonderful they are. I flew on Southwest this morning, guys, 6:30 in the morning.
Real man of the people.
But what I will tell you is the following. I know that my company has problems. I know that we could be doing a better job. The difference between us, and this is our problem in our industry, the difference between us and the other companies, if I can make an advertisement for our company, is we know we can do better, and we are going to take the words on our wall and we're going to fight really hard to close the gap between the words on the wall and what we actually do. And I don't think we have enough fight in this industry around that, because we convince ourselves that we're doing great.
You're also a private company and they're public.
We're not for profit.
Yep.
That matters. That actually matters.
Just to clarify, my brother worked for NVIDIA, so they took care of it. We didn't have to pay the $5,000 ambulance ride. So whatever it was, I think NVIDIA is self-insured, so ultimately I think whatever, they backed down, whatever the situation was. But I wanted to get back to what you said about hospitalizations and the fact that MA does a very good job of managing that cost. So I will read out to you some data. Don't kill me,
I'm not going to kill you.
But the reason for being for MA is very much, which was conceived as a cost control and providing a little more choice,
yes.
Right? So let's look at some of the studies that have gone on comparing MA to other stuff, to traditional Medicare. You guys already know this. This was actually discussed at a panel yesterday. In the March 2025 report, MedPAC projected that in 2025, the federal government would spend approximately $84 billion more for MA enrollees than if those beneficiaries were enrolled in traditional Medicare. This represents a 20% increase in spending for MA plans. That's one. KFF, Kaiser Family Foundation, they did an analysis in 2022 of 62 published studies on MA and Medicare since 2016 and concluded there's very few major differences in the two programs. Neither MA nor traditional Medicare performed consistently better across all quality measures. You love MA. Why? The data doesn't prove it.
No, let's talk about it. I actually care about people's affordability. Nothing in there actually talks about people's out-of-pocket affordability. And no one actually, at the end of the day, we have to think about the beneficiary, and we have to think about what they can pay for and what they can afford. And I will tell you something. I'm an American first. I'm a CEO of a health plan second. I think this program is expensive, and I think we need to fix aspects of it. And there are bad actors who've run away with risk adjustment, and we need to fix that. And the in-home assessment game has gotten out of control. And we offer supplemental benefits that lots of people don't use. And so there's a lot of deceptive practices in the industry, and a lot of people don't necessarily actually know what they're buying. So I'm the first person to call my baby ugly. But I was raised in an Indian family. You know what that means, okay? But what I will tell you, what I will tell you is the following, is that the other baby is uglier, okay? And so, like, I'm not gonna sit here and tell you that Medicare Advantage is perfect. There's a lot of bad practices out there. What I will tell you is that in the fee-for-service Medicare world, people get services that they don't need. Their doctors don't talk to them unless they get a paycheck every single time that they actually see them. There's very little focus on chronic disease management and wellness. There's, frankly, just people who are getting manhandled and very poorly coordinated care. So, and the other thing I'll tell you is in traditional Medicare, I don't know if you got the memo, there are no eyes, teeth, or
Yes.
ears, because there's no dental coverage, there's no vision coverage.
Yes.
And if you have ever talked to an older adult, do you know what they care about more than anything?
Teeth.
Their teeth. You're 100% right. They care about their teeth. But somehow my old colleagues at CMS didn't get the memo that, actually it's really Congress. I won't even blame folks at CMS. Congress has never actually said, hey, dental care is important, or the dentists have been really good in lobbying to make sure it doesn't get included in traditional Medicare. The reality is that we need to reboot these programs. But if you are a lower income older adult in this country, you just can't afford the other program. I mean, and the other thing I'll just say is it may cost more, but it may also be because it does more. And that's just something we don't talk enough about, which is we should be doing more for older adults in this country. These are the people who made this country. You know, we talk about whether seniors are, we talk about whether seniors are, able to use technology. Hell, they invented the internet, right? And what do we do for them when they age into Medicare? We give them a choice between something that's bad and something that's worse. My company's job, 4.5 stars, 7 out of the last 8 years, we sued CMS. Those lawsuits that Courtney referenced, we started that movement. We are fighting every single day to try to make this system better. Oz is talking about multi-year enrollment. That's an idea we've been putting out there. The truth is that we should all be focused on fixing the system. And one of the worst things that's happened right now in this industry is we just sit around, we talk about how great it is. And I'm glad you're asking these hard questions, and you always ask the hard questions, so thank you. But the truth is that without the hard questions, without the hard conversation, things never get better in society. And unfortunately, we've engaged in this culture and it needs to change.
So the last question, and if you have rotten eggs and tomatoes hidden in your purses, keep them hidden. Dr. Oz is not confirmed yet as CMS administrator, but here is one fact I recently learned, in fact, yesterday.
Yep.
He happens to be what many folks are in this room. He's a licensed insurance broker able to sell MA plans in 20 states. In fact, he remains licensed to this day. In his confirmation hearing, a Democratic senator asked his opinion on what he thinks are the biggest abuses right now in the private insurance sector. He said, and I quote, Medicare Advantage sales. He was asked to elaborate, and I will read that part. There's brokers that get involved in churning policies, so they get you to switch from policy to policy. We should potentially consider whether you need to re-elect Medicare Advantage every year and potentially offer multi-year programs for seniors, because that would save some of the money that the brokers are taking out of the middle. Some brokers do a great job, some don't. We probably have too many. So if a person who is a licensed broker is all but implying that this industry is full of middlemen, there is an image problem.
Let me say the following.
How do you attack that?
Arundhati, there are good journalists and there are bad journalists. There are good doctors and there are bad doctors. There are good CEOs and there's bad CEOs. And there's good brokers and there are bad brokers. And what I would tell you is a great broker, if you've ever met one, and I've met many over the course of my career, knows the star ratings, knows the benefits, knows the health systems, makes appointments for people, problem solves issues for people when they actually have issues. And bad people set it and forget it, okay? And they're not there to actually help their beneficiaries. And they give all of us a bad name, and they give the whole industry a bad name. And I've had this proposal out there for a while. You can look it up. It's in Forbes. It's the idea that we should recast brokers, because I think brokers just implies that all you're doing is selling something, as community health workers. Because what you're doing is really helping people navigate a really complicated healthcare system. If you're doing your job well, you're absolutely earning those renewal commissions. And if you're not, you're just setting it and forgetting it. And so I do think we need a cultural change in this industry. We need to shift the curve. I think we need to expect more, demand more, but pay people for what they're doing to actually serve people. And let me be clear, turn 65 and you figure it out by yourself, okay? It's not easy. It's not easy. I will tell you that there are brokers who will enroll your in-laws in a competitor's product That's a story for another day.
It's my parents, not in-laws.
No. My in-laws.
Oh, okay.
My in-laws were enrolled by a broker in a competitor's product. That's a story for another day. Never do that, guys. Never do that. But what I will tell you is we really need to shift the curve. Everybody needs to be better. Like in this time when healthcare is as broken as it is, we can't kind of defend the status quo. If you defend the status quo, you're a part of the problem. And I think all of us know that every part of healthcare, Medicare Advantage distribution, the health systems, we all have our problems. Let's own our problems, let's commit to fixing them, and let's make them better.
And I think given the cuts that we're going to see, already seeing in CMS and HHS, there's probably an opportunity for folks in the room to be that support for the seniors moving forward.
100%.
On that hopeful note, thank you so much. Thanks, Sachin.
Thank you.